Good day, everyone! Welcome to our discussion about cardiovascular and circulatory function. For the learning outcomes at the end of this discussion, the students will be able to conduct assessment of the cardiovascular function and be able to describe the structure and function of the cardiovascular system and its associated risk factors. Identify major manifestations of cardiovascular dysfunctions, identify as well diagnostic tests of the cardiovascular system, and discuss nursing interventions and management. For the anatomy of the heart, so we have here the structure, okay, an illustration of the structure of the heart. So the heart is a hollow muscular organ in the center of the thorax. It actually occupies space between the lungs, that's the mediastinum, and the rest of the diaphragm. Approximately, it weighs 300 grams or 10.6 ounces. It has 3 layers, right? So we have here the endocardium, okay? We have the myocardium and epicardium. Moving on, there are also heart chambers. So we have the atria. Okay, so for the atria, it produces rhythmic relaxation and contraction of the muscular walls of its 2 top chambers. Okay, so here, all right, and then so we have the right atrium and we also have the left atrium. All right, so at the bottom you can find the ventricles. So that's in the bottom chambers. Right, and for the diastole, okay, it's actually in charge of the ventricular filling, and systole is in charge as well on the contraction of the atria. For the right side of the heart, you can find, of course, the right atrium and you also have the right ventricle. Okay, so the right atrium and right ventricle distributes venous blood to the lungs via pulmonary artery for oxygenation. Okay, the right atrium receives blood returning to the heart, okay, from the superior vena cava, okay, and inferior vena cava coronary sinus as well. So on the left side, okay, you can of course find here the left atrium, and at the bottom we have the left ventricle. So they are the ones in charge of distributing oxygenated blood to the remainder of the body via the aorta. Okay, and then the left atrium, on the other hand, receives oxygenated blood from the pulmonary circulation via pulmonary veins. Let's now have the functions of the heart. So we have cardiac electrophysiology. Imagine that see it as that your heart has conduction system. So it's like the wiring of a house. So it controls the rhythm and pace of your heartbeat. Okay, so this includes the sinoatrial node. Okay, so which refers to the primary pacemaker of the heart, and its normal rate is within the range of 60 to 100 impulses per minute. Okay, we also have the atrioventricular node. This one receives impulses from the SA node, okay, and then what happens if SA node fails? So if that happens, the atrioventricular node can initiate and sustain only a heart rate of 40 to 60 beats per minute. So then again, of course, it's not enough compared to the normal rate that SA node produces, which is 60 to 100 impulses per minute. So we also have here part of the still cardioelectrophysiology. We have the electrical bundles and fibers. Okay, so we have the left bundle. Okay, the left bundle branch sends electric impulses to the left ventricle. Okay, and then the right bundle branch, on the other hand, sends impulses to the right ventricle. Okay, and we also have the other one sends impulses from AV node to the Purkinje fibers as well. So when we say Purkinje fibers, they are the ones okay, in charge in diffusing network of conducting strands which spread the polarization through ventricles. So we have here the dynamics, okay, cardiac hemodynamics. So this is an important determinant of blood flow in the cardiovascular system, okay, with the principle that fluid flows from a region of higher to lower pressure. So the pressure or the pressures responsible for blood flow in the normal circulation are generated during the systole and diastole. Okay. So what happens here is that during the diastole, okay, where we say that this is on the state of having a relaxed heart, okay, so during the diastole, all four heart chambers, that's the right atrium, right ventricle, left atrium, and left ventricle, they are all relaxed, okay, and then the atrioventricular valves are open and semilunar valves are closed. So just imagine, again, pressures in all of the chambers are lowest during the diastole because as we mentioned, it's the relaxed state, right? Okay, this now facilitates the ventricular filling. Okay, so venous blood returns from the lungs via the four pulmonary veins, okay, into the left atrium and a ventricle. So again, on the left side, we have oxygenated blood that returns, okay, from the lungs via the four pulmonary veins into the left atrium and the ventricle. So toward the end of the diastolic period, atrial systole, okay, occurs as the atrial muscles contract in response to an electrical pressure, okay, by ejecting how many percent? Okay, we have a blood volume by 15 to 25%, all right, and is sometimes referred to as atrial kick, okay. So this ventricular systole begins in response to propagate the electrical impulse that began in the sinoatrial node, okay, some milliseconds earlier. So beginning, we have here the beginning of ventricular systole, okay, the pressure inside the ventricles rapidly increases and then forcing the AV valves to close. As a result, blood ceases to flow, okay, from the aorta into the ventricles. And with that, again, we can prevent regurgitation or the backflow of the blood, okay, into the atria. We don't like that, okay. And then next is that we have here the rapid increase in the pressure inside the right and left ventricles, which forces the pulmonic and aortic valves to open, and the blood is ejected into the pulmonary artery and to the aorta. So the exit of the blood is at first rapid, and then as pressure in each ventricle and its corresponding artery equalizes, the flow gradually decreases. Then at the end of the systole, pressure within the right and left ventricles rapidly decreases. As a result, okay, pulmonary artery or arterial and aortic pressures decrease, causing closure of the semilunar valves. And then again, this event marked the onset of the diastole, and cardiac cycle once again is going to be repeated. So we have the second one, we have the cardiac output. So you've heard this cardiac output, right, when actually you were perhaps on the second year. Okay, so cardiac output is referring to the total amount of blood ejected by one of the ventricles in liters per minute. So we have the normal cardiac output in resting adult is 4 to 6 liters per minute, but it actually varies greatly depending on the metabolic needs of the body. But this usually is the range, normal range. For the cardiac output, we can compute for this one, okay, by getting the stroke volume, and then we multiply it by the heart rate. So The stroke volume, on the other hand, just to have a review, is the amount of blood ejected, okay, from the ventricles per heartbeat. So average stroke volume is 60 to 130 ml. So just a review once again, normal heart rate, okay, we have here the range from 60 to 100 beats per minute. If it falls below, okay, 60 beats per minute, we call that sinus bradycardia. If it is more than 100 beats per minute, it is called sinus tachycardia. Okay, have you heard of autonomic nervous system? Do you still remember this one? This is very important. I think, as you can remember, autonomic nervous system is kind of always present when, or you can remember when you are under stress. Okay, so we have here the stimulation of the sympathetic nerve fibers. We also have the parasympathetic nerve fibers. So let's talk about first, we have here the sympathetic nerve fibers. So this releases the norepinephrine. Okay, once it's released, then you can observe that there'll be what? Increase in heart rate. If that happens, then the conduction speed as well increases. Atrial and ventricular contractility again increases, and you can find out or also see, rather observe for peripheral vasoconstriction. So you can have these are the signs, okay? However, on the other hand, if it is the stimulation of the parasympathetic nerve fibers, where it releases acetylcholine, okay, this is in contrast of the effect when there is release of norepinephrine. Because again, in terms of heart rate, there is decreased heart rate when acetylcholine is released. And then, what else? It lessens atrial and ventricular contractility and conductivity. So, this stimulation occurs when there is increased in pressure, okay, as detected. Okay, so heart rate. Heart rate are receptors located in the walls of the aortic arch and carotid sinuses. So, specialized nerve endings affected by changes in the arterial blood pressure. Okay, so it's affected. What else? Arterial pressure stimulate the baroreceptors, which decreases the heart rate and arterial pressure. Okay, so we have here the factors affecting the structure and function of the heart. So let's talk about the age. Okay, as an individual ages, okay, there is what? Loss of function of the cells throughout the conduction system. Okay, so can we expect, okay, increasing or decreasing heart rate? Okay, so we have here decreasing or slower. Rather, we say slower heart rate. So there is also increasing size of the heart due to hypertrophy. Hypertrophy happens when there's thickening, or we refer to it as the thickening of the heart walls. So thereby, the size of the heart would really increase. Okay, and there will also be decrease in the volume of blood. Okay, so the valves, due to stiffening, no longer close properly. Okay, so again, if that happens, there's a tendency that there'll be backflow. Remember the regurgitation? Okay, and you will hear additional or extra heart sounds, and that's murmurs. Okay, so we also have here, again, as you age, it takes longer to compensate from increased metabolic demands. Also, it is evident by several with these symptoms like fatigue, shortness of breathing, palpitation. Okay, so age-related changes takes longer again to compensate from increased metabolic demands because of what? Stress. What else? Some because of exercise or illness, and this is again what can be felt. All right. this is an illustration of age-associated changes that occurs in heart and vascular system. Okay, so as you can see, this one is the normal. Okay, we have the normal young heart, which is highly functional or has highly functional cardiomyocytes. So when you say cardiomyocytes, these are cells responsible for generating contractile force of the heart, and it shows a normal atrium and ventricles. Okay, so this one. All right, and on the other hand, young artery, okay, has normal lumen. So this one. All right, so this is the normal lumen, and as you can see, the arterial thickness again is not that thick. Okay, and what else? It has efficient contractile and relaxation properties. Okay, so it actually relaxes and contracts, okay, regularly or evenly. On the other hand, age-associated or aged heart has increased thickness, okay, in the heart muscles. So this one, compare the heart muscles of this aged heart to the young or normal heart. Okay, so here you can see that there is already hypertrophy. Okay, so there is increase in thickness in the heart muscles due to hypertrophy or increase in the size of the cells. So specifically, cardiomyocytes, okay, is undergoing senescence. So aged artery are also, okay, evident on its increased thickness. So take note of this one. Okay, take note of this one compared to this one. So there is thickness. What else? There's reduced lumen. Okay, so it's reduced compared to this one, and it again, because of those characteristics, it now gives less efficient contractility and relaxation properties. So just imagine, again, with this kind of artery having a blood flow, okay, is again, you can imagine that it will still be efficient, okay, as it passes this artery, compared to the aged artery, which has what? Okay, reduced lumen. So that's why we say that the contractile and relaxation properties are less efficient. Moving on. Okay, what are the factors affecting the structure and function of the heart? Again, a while ago we've mentioned the age. Now we have gender. So here we have women. Okay, what about women? The heart of a woman tends to be smaller than that of a man. So the coronary arteries are also narrower in terms of diameter. Okay, so with that, when atherosclerosis happens, cardiac catheterization and angioplasty is more difficult. Okay, so typically women develop coronary artery disease later than men due to cardioprotective effects of female hormone called estrogen. Okay, so what are the major effects of estrogen? So it increases in it's increase in high density lipoprotein or HDL. This is called the good cholesterol. Okay, and of course what's good again is that there is reduction in low density lipoprotein, which is known as the bad cholesterol. So what else? A dilation of the blood vessel, which enhance the blood flow to the heart. Again, these are again factors that can affect the transport or the blood flow to the heart. So although we can say that estrogen has good effects, okay, again, it's not recommended that that women also undergo hormone therapy, okay, to prevent coronary artery disease. So let's now have the assessment of the cardiovascular system. So how do you assess whenever you're in the clinical area, you're faced with a client, okay, who has some cardiovascular disorder? Okay, so in terms of assessment, again, of course, you know that you have to do an interview. Again, check the client's health history, and part of it is knowing the ethnic background. So part of this one, women, African Americans, and older patients are reported to delay seeking, okay, as per study. What else? We also have to consider socioeconomic factors. So you ask questions in terms of socioeconomic factors, like in terms of poverty. You also have the access of the patient into having like, or to seeking consultation. Okay, so it's like is the hospital facility near or accessible to the client? And then what else? Do they know anything about cardiovascular diseases? What else? Like, is there any stigma on being, like, for example, being overweight? So with this, you have to be careful when you ask questions. So again, be factual. Do not impose any self-demeaning questions. Be more sensitive, especially on you know, in terms of asking weight. So here, you also have to ask the past health history of the client. Okay, what else? Also, you have to ask about diseases that runs in the family, and any social history, okay, that can contribute to cardiovascular disease. So we have common symptoms of cardiovascular diseases. Okay, so there's like chest pain or discomfort, shortness of breathing, peripheral edema, okay, palpitations, and then is there any unusual fatigue that's being felt by the patient? What else? You also need to ask the client's medication, like for example, any intake of vitamins. So you have to specify those, herbs and other medications taken, be it prescribed or not prescribed. Okay, also you have to ask if there's any antiplatelet drugs being taken, its dose, its frequency, and then when was it prescribed. Okay, so when we say antiplatelet drugs, an example, we have aspirin. Again, you have to take note as well of its side effects or adverse reaction as well. Okay, so anything also that they take, like you have the second antiplatelet inhibitor medication, we have clopidogrel, ticagrelor, okay, and primarily, again, these are anticoagulants. Okay, so it's being taken to they are blood thinners. Okay, in a simple term, they are blood thinners. So it prevents coagulation thereby of the blood. Okay, however, there are side effects: nausea, vomiting, gastric irritation. They're also prone to bleeding. Okay, so in terms of nutrition, so you also, of course, asking the weight. What's the point of asking the weight? Then you have to compute for the body mass index. So you also have to ask, or to, you know, to check if they do self-monitoring of blood glucose level, and how do they do it. Okay, also the frequency and the manner of conducting such blood glucose test. So what else? So you can also have an interview about the 3-day diet recall. What's their usual food intake? And how do they prepare their food? Is it more of a fry, saute, boiled, stew, and so many more? What else? In terms of elimination, okay, so you ask what's the typical bowel and bladder habits, how many times do they eliminate, okay, or have bowel movement a day, do they experience nocturia? What else? Do they strain during defecation? Okay, so you have to also to ask if they urinate at night, how many times do they do that? Okay, and then what else? You also have to ask about the activity. Okay, so what's their usual activities a day, a week? Okay, whenever they do such activities, do they experience any fatigue? Okay, do they become somewhat restless? So, check again if they're taking medication. So, this beta-adrenergic blocking agents, again, check if it's part of the medication, because they might be suffering some side effects whenever they do exercise or some activities. What else? For the sleep and rest, you have to ask if they ever experience like sleep disordered breathing, they have difficulty breathing whenever they sleep, or like their significant others have told them that they have loud snore, and then they actually don't feel rested whenever they sleep because they actually get bothered by sleep disordered breathing. Another one, we have self-perception and self-concept. So here, you have to ask the patient, okay? Again, this is their perception. This is how things, really gets into their mind. So this is what they believe. So please avoid, making judgments. So ask, how do they perceive their overall health? Do they think that they're healthy? Okay, so what makes them think that they are? Okay, and then what else? What are the determinants to self-care? Okay, how do they adhere to self-care? So there are several things, one of which somehow, of course, their ability to do so. What else? Their resources, okay, and their, when you say it is their ability, like can they still manage to independently do self-care by themselves? So what else? So in terms of roles and relationships, do they get social support? Okay, and then are there anyone in the family, okay, that that can influence them in terms of their illness? Maybe that person could somehow motivate, okay, or is really important to the person, and listens to that person. That's very important. And then what else? Because of getting sick, does it affect the role of the patient in the family? Like, for example, the father, who is the breadwinner, suddenly has cardiovascular disease. Then this limits him to work for the family, to earn, okay, for the family. So next, we have sexuality and reproduction. So in sexuality and reproduction, you also have to ask, okay, with no malice, all right, about physical exertion on sexual activity, okay? So what do they experience whenever they are engaged in sexual activity, in terms of breathing, in terms of perhaps they can observe their heart rate if they are knowledgeable enough about it, okay? And then do your clients, or does the client experience like sadness or maybe depression or anxiety because of erectile dysfunction? Okay, next is the coping and stress tolerance. So coping and stress tolerance, so these are actually being affected or influenced by several lifestyle factors. Like whenever an individual gets under stress, okay, what are the factors that, or lifestyle practices that's being practiced? Like, do they eat a lot? Okay, what else? Do they sleep a lot? Do they work out? Okay, how do they really cope with stress? And are there any behavioral factors that's being practiced or that are evident? Like, for example, they're into substance abuse, they isolate themselves, okay? They, of course, if they isolate themselves, they don't have any more the motivation to work, to mingle with others. Okay, so as you can notice, again, this one, or the previous factors that you are going to assess for is part of the Gordon's functional health patterns, okay, that you can review. So we also have to conduct, of course, the physical examination, and still remember how to do it using several techniques of inspection. Okay, palpation, percussion, auscultation. Also, you check vital signs and then take note if there's any changes on blood pressure, pulse rate, respiratory rate. Okay, and then whenever you auscultate for the heart sounds, you take note if there is extra heart sound that you can hear. So that could be murmur or gallop. Okay, so we're done with the way you conduct assessment. Okay, now how do you now recognize some diagnostic tests? Okay, so this is actually important. Some of your clients will have more idea about this one. You can help them in explaining their diagnostic test. Okay, so most of the time you can see here in the lipid profile. Okay, the lipid profile is a test that measures the risk for developing coronary artery disease. So the lipid profile has its measurement in terms of cholesterol and in terms of triglycerides. Okay, so when we say cholesterol, again, you can see there HDL and LDL. Again, I have mentioned a while ago that high-density lipoprotein, okay, is considered as good cholesterol. Most of the diagnostic centers, whenever they come up or whenever they issue, of course, the result of the client, they actually have normal limits, okay, normal range. So you can also refer to that one to verify if there's if the measurement is high or low, or or normal. So HDL, or high density lipoprotein, is considered as good cholesterol. So of course we want this of course normal, or what else, right? We also it's also, some would also consider that it's okay to have this higher. Okay, on the other hand, low density lipoprotein, okay, of course, again, we want this normal. Okay, because this is bad cholesterol, we want it in normal range. However, again, if it is high, if it is or it falls in high range, then that is not good, because it means to say that there's bad cholesterol. Okay, there's more bad cholesterol in your arteries. So what else? You can also check for the total cholesterol level. They actually compute this one. They calculate by summing up the HDL and LDL and 20% of the triglyceride. Okay, so triglycerides, okay, on the other hand, are fatty, free fatty acids. Okay, we can get this from the food that we eat. Okay, so again, it's composed of free fatty acids and glycerol. Okay, so glycerol, okay, it comes from also from carbohydrates as well. Okay, and then again, what else? And fatty acids. So that's a combination of triglycerides. So usually it increases after meals. Your triglycerides increases after meals. That's actually one of the reasons why it requires the patient to have fasting for like 12 hours. But this one is actually, it varies from protocols of diagnostic centers. Some would have it at least 10, but it's 10 to 12 hours. Okay, so again, there's fasting, because if you have taken food and you'll have your lipid profile measured, then again, there'll be what? There'll be an increased measurement. So it's not reliable. Okay, with fasting, you can have an accurate result. So triglyceride increases after meals, going back. What else? It's also increased among patients with diabetes mellitus, increased as well among patients who regularly have intake of alcohol, and it is increased as well among obese clients. What else? Triglycerides is also affected by stress. Okay? So there. What else? Now, what can we do as nurses? Okay, so in terms of nursing consideration, we have to consider the factors that contribute in cholesterol levels based on our assessment, of course. So, again, how old is the client? What's the client's gender? Okay, is there any diet or exercise pattern? Okay, in terms of family history, okay, is there any cardiovascular disease? Is the client, if women, menopause already? Do they smoke cigarettes? What's their stress level? Like, whenever, do they have positive coping skills? Okay, so basically, again, you can include this modifications if they need modifications. You can include that in your health teaching. So you have lifestyle modification health teachings. And then if your client or your patient has been diagnosed to have high cholesterol already, or coronary artery disease, then you can also discuss the side effects, the indications as well of cholesterol lowering medications, such as those statins. Okay, we also have non-statins that you also need to explain what they are for and what has to be prevented. Okay, another one, you have the blood chemistry. Okay, so in blood chemistry, you can find blood urea nitrogen, calcium, creatinine. Okay, so for blood urea nitrogen, normal reference range is from 80 to 20 milligrams per deciliter. So this one, if there is increased BUN, it means that there is reduced renal perfusion and decreased cardiac output. Okay, this is in some, you also have to check if the client is on medication. Okay, because some of medications could lead to could be diuretics. Okay, so there'll be more fluid loss. Okay, calcium, if there is low calcium with this based on this reference, okay, what can you expect from that one? Okay, so it slows nodal function and impair myocardial contractility. Okay, so this one increases the risk for heart failure, again because of impaired or slowed myocardial contractility. If there is increased or more than, okay, more than the normal range of calcium, okay, this can actually happen with the administration of diuretics. Okay, because this will reduce renal excretion of calcium. So this potentiates digitalis toxicity, which will again increase the risk for myocardial contractility. What else? Heart block and sudden death from ventricular fibrillation. Next, you have creatinine. So you check if your client is either male or female because they have different reference range. So a normal creatinine level, again, if the creatinine is normal but there is increase in BUN, it could suggest an intravascular fluid volume deficit. So you have to check this one, to check the creatinine and the BUN. So what else? We also have magnesium. So hypomagnesemia, that's what we call when there is lower than normal range of magnesium. So this is due to the enhanced renal excretion of the magnesium from the use of diuretics, digitalis therapy. Okay, as again, I've mentioned a while ago, with diuretics, it will what? It will increase fluid loss. So hypermagnesemia, if there is some more than of this measured or range, then again this is actually due to okay, contractility of the myocardium heart, okay, and again, this is commonly caused by the use of antacids containing magnesium. So what happens with the myocardium is that it depresses the contractility, okay. Then if it keeps on happening, then it will become asystole. Potassium, on the other hand, with this normal range, okay, again, if lower than 3.5, we call that hypokalemia. So, if it is due to administration of potassium-excreting diuretics, then it can cause what? Arrhythmia, ventricular tachycardia, worse is fibrillation. So, if it is, so there, you can also see that if there is hyperkalemia, again, it will inhibit the aldosterone function, and there will be heart block, asystole, and life-threatening ventricular arrhythmias. Sodium, okay, so hyponatremia, that's below 135 milliequivalent per liter. So this indicates fluid excess, okay, which can of course be caused by heart failure, okay, or administration of thiazide diuretics. If there is hypernatremia more than 145 milliequivalent per liter, it indicates fluid deficits and can result to decreased water intake through excessive sweating or diarrhea. Okay, later on during our discussion of cardiovascular disorders, you can appreciate more of the use or application of those, okay, part of which is the chest x-ray. Okay, so chest x-ray is one of diagnostic procedures that's being obtained to determine the size, contour, and the position of the heart, okay. So again, it can also show cardiac and pericardial calcification. So it will also demonstrate physiologic alteration in pulmonary circulation. Alright, what else? It shows correct placement of pacemakers if there's any. What else? And can help diagnose some heart complications like heart failure. So you have here fluoroscopy. Fluoroscopy is an X-ray imaging technique, so it allows visualization of the heart on screen. So it shows cardiac and vascular pulsation and unusual cardiac contours. So it's more, it can be more seen here compared to X-ray. So it also shows cardiac and vascular pulsations and unusual cardiac contours. So it's useful aid for positioning transvenous and venous catheters because it's more precise. ECG, okay. ECG is a graphic representation of the electrical activity of the heart. So you, I don't know if you've seen a patient having ECG, but again, for ECG, it's being conducted by placing disposable electrodes in standard position of the skin. So this is where you place the electrodes, okay. In addition, you also have this, and the right arm, left arm, the right leg, and the left leg. Okay, it's going to be recorded at a speed of 25 millimeters per second, and here are the boxes, okay, yeah, there. What else? The voltage are calibrated so that you can have here into, or it can point into the vertical direction. So again, this is the strip that you can see, and it shows whenever you see an ECG strip, it's not going to give you this, the PRQ or the PQRST letters. No, what you can only see are this one, the movement, the impulse, or the activity of the heart. So there, we'll discuss this more in the conduction system. Okay, so there, yeah, the P wave represents the wave of depolarization. Okay, so this is the P wave. I'll discuss this more in the conduction system, by the way. And then we also have the QRS complex. Okay, so the QRS complex represents ventricular depolarization. So normal is, in terms of duration, is 0.06 to 0.10 seconds. So this is actually relatively short in duration. Okay, as it indicates ventricular depolarization. Okay, so if it is prolonged in terms of duration, okay, then the conduction is impaired with the ventricles. And then there, what else? It actually involves more of the pacemaker. So just for illustration, because we'll be discussing this more later on, okay, here is the ST segment. Okay, the ST segment. So the beginning of the T wave is the time of which both ventricles are completely depolarized, and then this is actually for the diagnosis of ventricular ischemia or hypoxia. You also have the T and U. U waves are not normally seen. Okay, so this segment roughly corresponds to the plateau phase of the ventricular contraction, as you can see there. Okay, so T and U, positive U may be seen following a T wave. Okay, so it represents the last remnants of the ventricular repolarization. We can differentiate this one. We have 12 lead ECG, 15 lead ECG, and 18 lead. So for 12, it's used to diagnose arrhythmia. So you can check there any abnormalities in the conduction, chamber enlargement, ischemia, injury, infarction. If it is a 15 lead ECG, it adds 3 additional chest leads across the right precordium, and it's used for early diagnosis of right ventricular and left posterior infarction. 18 lead is useful for early detection of MI or myocardial ischemia and injury. Okay, so we also have here cardiac stress testing. For cardiac stress testing, again, you're going to check for any abnormalities in cardiovascular functions. Okay, and then as you can see here, the patient is being must be assisted. Okay, in using the treadmill. So the patient walks or runs on a treadmill or pedals a stationary bicycle, and then the following must be monitored: 2 or more ECG leads for heart rate, rhythm, BP. Okay, can also be checked. Also, you have to monitor or assess the appearance of the patient, especially if there's paleness or if the skin's getting cold, okay, or there's pallor. So also check if there's any signs of chest pain being manifested. Ask the client if there's like fatigue or there's difficulty of breathing. So it's very important that you, as as a nurse, instruct the client prior to test, okay? Instruct the client to fast for several hours. This must be specified per protocol, okay? And avoid stimulants, no caffeinated drinks, no tobacco use, okay? And then the client may be advised to hold beta blockers, calcium channel blockers, and digitalis for 48 hours before the stress test, okay? And then must wear comfortable shirt and rubber-soled sneakers. This one, again, to protect the client from any injury, because the client might slip off the treadmill if without the rubber-soled sneakers, and they must wear comfortable shirt and clothes as well, or the shorts. What else? All right, having said that, of course, the nurse must explain the procedure to the client, its duration, and the things that the client should do in order to participate well and have a smooth conduct of exercise stress testing. Okay, so we have here in terms of pharmacology, we have vasodilating agents, okay? So vasodilating agents, they dilate coronary arteries and identify stenotic arteries that cannot vasodilate. However, there are some side effects, okay? So you have to ask the client taking this kind of drugs if anything that they experience, any untoward effect that they experience, but not leading, of course, to chest pain. Like, do you feel any chest pain? You don't ask directly about such chest pain, okay? You just, let the client say it. So any like headache, flushing, nausea, difficulty of breathing, or dyspnea, adenosine has short half-life. Alright, this is part of vasodilating agent. So why is it specified? Meaning to say that in 10 seconds, okay, again, the effect will really be evident to the patient already. Wbutamine increases heart rate, on the other hand, and with that, myocardial contractility also is evident, and then blood pressure, okay, as well. So for this one, okay, nursing intervention, again, NPO for like 3 hours prior to procedure. So still, I'm talking about here part of the stress testing, okay? So NPO, and then no foods with caffeine or chocolate. These are stimulants, okay, within 24 hours, and then will be asked to stop taking aminophylline, theophylline, and this dipyridamole, okay, before the test, the vasodilating agents. So we also have echocardiography. This is a non-invasive ultrasound test. It's used to measure the ejection fraction and examine the size, shape, and motion of cardiac structures. So you have to explain to the client that the procedure is not painful. Also, you have to explain that there will be a transducer, okay, that will be used, which will emit sound waves and move over the surface of the chest wall, which take around 30 to 45 minutes. Okay. So next we have cardiac catheterization. So this one is a common, okay, invasive procedure. So take note that it is invasive. So it is used to diagnose structural and functional diseases of the heart and great vessels. So, given this one, this cardiac catheterization, this will result to, in a way, guide the treatment decision. So, include which sometimes, of course, there's a need for revascularization and other interventions to manage the structural defects of the valves or septum. Okay, so cardiac catheterization can be of this one axis, and the other alternative site is through radial. So here, okay. Okay, so that goes well for our discussion. Alright, so here are the references that actually we'll be using for the entire semester. We'll just be adding maybe some references as well, some sites. Okay, so I hope that you're able to learn something about our discussion. And again, with that, I would like to say thank you. Maraming salamat po. You are all welcome to ask questions during our meeting. Okay? See you all!